Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Starting in January 2024, the city of Flint, Michigan will be the first in the country to offer cash payments to new parents, each of them in the city. By tackling poverty, the project aims to improve health, well-being, and economic development. Behind the effort is Dr. Mona Hanna-Attisha, the pediatrician who exposed the Flint water crisis several years ago. She joins the podcast with her colleague, Michigan public policy professor Luke Shaefer. They speak to Dr. Sharfstein about the new effort and why it's needed. You can read more at flintrxkids.com. We'll include the link in the show notes. Also, Professor Shaefer's new book is The Injustice of Place. Let's listen.
Mona Hanna-Attisha, Luke Shaefer, thank you so much for joining me, Public Health on Call. And to be honest, I'm particularly excited that, Mona, you're here in the studio with me.
It's so wonderful to be here. And Josh, in person, it's so wonderful to give you a hug.
So we are here to talk about some very exciting news out of Flint, Michigan. Now, most people would know you for your incredible work during the Flint water crisis. You're a pediatrician who works in Flint. Tell us what this project is about.
So, Josh, we are launching something in Flint called RxKids, Prescription Kids, and it is the first ever effort to eliminate maternal and infant poverty with universal and unconditional citywide prenatal and infant cash allowances.
Tell me the details. When will this start? How much money? How will it work?
Oh, my goodness. So it will start in January of 2024. Every pregnant mom will receive a one-time $1,500 unconditional cash allowance around mid-pregnancy. And then once a baby is born, they will receive $500 a month for the first year of life.
I have so many questions and to ask and so much to appreciate about the work that's gone into this. But I want to take a step back and say, how did you get from lead in the water to poverty?
Well, I think the common thread is I'm a pediatrician, you're a pediatrician. We have this amazing privilege to care for our children. And our work is not so much about taking care of the kid in front of us today, but our work is about making sure that that newborn in our arms has the brightest future possible, right? And I have been frustrated for a long time with my inability to prescribe away poverty. It's a root cause determinant of health. It's one of these kind of toxic social determinants. And Flint is the poorest city in our state. We have poverty rates that far exceed state and national averages. And when I am a pediatrician and I am caring for our kiddos, and when I know the consequences of being born into and growing up in poverty and not having the ability to do anything about it, that's frustrating. And that's really what birthed this project, to be able to do something about it.
I recall from my time in the clinic that housing issues were a huge source of poor health for families, for kids, through asthma and other conditions. There were problems getting enough food to eat.
Yes.
What are the kinds of consequences that you've seen from poverty?
Yeah. So, so much of what we care for in medicine that could have been prevented is connected to poverty. So child development is connected to poverty. Violence, abuse, neglect is connected to poverty. You mentioned food insecurity, not having enough money to eat good food. Housing stability, enrichments for children, maternal stress and bandwidth. My parents in Flint, they love their kids just like you and I love our kids. But without the resources, it's very hard to provide families everything they need, children everything they need to be healthy and successful.
Now, I completely agree. And I'm also struck by the fact that you are not just aiming to support a few parents in your
Yeah.
practice. You're thinking about it at the community level. And I want to
Yes.
ask you about poverty when it is affecting not just 1 or 2 or 10 families, but an entire community. What additional health challenges does that pose?
Yeah. So when poverty is concentrated, when all of your neighbors are poor, when it's chronic, when it's especially endemic in early childhood, all of those things together, especially kind of that community rate of poverty, portends even worse life course outcomes. It's harder to get out of poverty when it's so concentrated in your neighborhood. We mapped out our city with geographers, with a Bloomberg grad geographer. There's areas throughout the city in census tracts where the poverty rate for young children in those neighborhoods exceeds 80%. Like, that is jaw-dropping that in neighborhoods, 80% of young children are growing up in poverty. So, then there's this kind of almost hopelessness and a lack of opportunity. One of my favorite questions I ask my patients, I think it's one of many pediatricians' favorite questions, is like, what do you want to be when you grow up? And so often I get blank stares from children when I ask them, what do you want to be when you grow up? Because of that lack of hope, because of that chronic, concentrated poverty.
Luke, I want to turn to you because you study chronic, concentrated poverty. First, what do you think about what Flint is intending to do?
Well, I couldn't be more excited about anything like I am about RxKids. A lot of my work has been on child benefits, and this is a policy that's been tried all over the world to say raising kids is expensive, and society has a reason to come alongside parents in that work. And every time this is done, child poverty plummets, but following the things Mona mentioned, food insecurity drops, housing stability improves. We see credit get better for families as they pay down debt a lot of times, and kids do better on so many outcomes. One thing I would just add in terms of understanding poverty and then concentrated poverty when you're growing up poor and everyone around you is more often low income. Just one more element to add is instability and volatility. So we've often thought of poverty as not having enough money to meet your basic needs. The federal poverty line is something like $26,000 for a family of 3. But so much more, it's also about huge swings in income as families lose jobs in an unstable and volatile labor market, or families, have challenges with housing and they're moving from place to place, family composition. All of this instability means that families are just constantly sort of managing instability, and that's really hard for anyone. And the biggest sort of moment of financial instability for families is right around childbirth. So we can see incomes of families just plummet in the months right before childbirth and stay well below where they were all the way to age 1. And so as I've gotten to hang out with Mona and other great pediatricians and public health experts, I've come to understand that this is this critical time in the development of babies that shapes their life course for decades into the future. And so that's why it's such an important moment to intervene.
That is really helpful to hear. I want to take a quick step back because I know that you have just written a book about the origins of concentrated poverty in the United States. And can you just tell us a little bit about where this comes from? How do we get to a point where an initiative like this is needed? How does it happen that there are 80% of the kids growing up poor in one neighborhood? And what does that look like as you looked around the country?
Yeah, thanks, Josh. So the great book on this topic is William Julius Wilson's The Truly Disadvantaged, that looked at urban communities and the concentration of poverty. And I think the thing that we started to learn from that work was that you can't understand why there would be such incredible jaw-dropping poverty is, as Mona says, like this concentration in communities without understanding history and understanding a set of policy choices. A set of policy choices that segregated us by race, have segregated us by income, and have been perpetuated over time. And I think some people are aware of, redlining and highways and a set of policies in the last 50 or 60 years that have segregated us as a nation and also like cut off resources to certain communities. The book that I've just written with Kathy Eden and Tim Nelson, The Injustice of Place, actually looks at concentrated poverty in rural areas in the United States too. We tried to take a sort of multidimensional approach to understanding poverty, not just as a lack of income, but as Mona was laying out, challenges with social mobility. In some places, if you grow up poor, you're just as likely to rise to the middle class as others. In many other places, if you grow up poor, you're likely to be poor as an adult, as well as health outcomes. So looking at infant outcomes and also life expectancy. We use all that data to zero in on the places that we think have the greatest challenges for counties and cities in the United States. And we're struck by the fact that so many of the places that have extremely high poverty rates, really poor health outcomes, and low rates of social mobility are rural. There are places in Appalachia and the Cotton Belt, as well as South Texas and tribal lands as we go out west.
In your book, you talk about some common themes about these places, including a history of exploitation of workers, as well as government dysfunction and corruption. When you look at a place like Flint, where famously there were big corporations that left, and there was all kinds of government dysfunction that led to the Flint water crisis, do you feel some similarities?
I'll answer for Luke.
Sure.
Absolutely. Flint was the birthplace of the automobile industry, General Motors, a long history of extreme capitalism, exploitation of workers, which caused a backlash, really the birth of the unions and the middle class, but still, globalization, automation that left the city abandoned with lots of unemployment, and also a long history of corruption, not just that led to that acutely with the Flint water crisis, but also chronically.
So you're stepping into the situation with a program focused on families. Mm-hmm. Why start there?
Oh, Josh. Well, it's focused on families. It's focused on moms and babies. We wanted to do this for all of childhood, like child allowances in many other countries. Luke says child allowances are the evidence-based policies of evidence-based policies. Like most other westernized countries, developed countries have child allowances with a really strong evidence base. We as a nation did this during COVID. We expanded the child tax credit thanks to Luke and his colleagues. We lifted almost 4 million kids out of poverty, and we proved as a nation that we can care for each other. We can do good things, and we saw great outcomes like decreased nutrition insecurity and decreased parental stress and decreased abuse and neglect, and the list goes, better infant outcomes. We don't have a lot of money. We wanted to figure out how to do this. Flint's a small, big city, the poorest city in our state. And when we decided what to focus on, we focused on moms and babies, pregnant moms and babies, to address the maternal-infant health disparities, maternal morbidity, maternal mortality, infant mortality, prematurity, NICU admission, low birth weight, and to really provide that stability in the first year of life. And I wanted to do this for like pediatrician science reasons. And then we learned, Luke shared that this perinatal period is also the same period of the greatest economic vulnerability, that families are the most poor. So that's why we narrowed this down to the mom-baby period. But the beauty of this project, which is unlike any other income cash transfer work that is happening in our nation, it is for the entire city. And that affords us the ability to measure community outcomes. Like, what does it do to population stability? Do people move to Flint? What does it do to economic reinvestment? The majority of this money is going to get spent back in the community. And I think some of my favorite things that I'm looking at, the mechanism of action here is cash transfers. It's economic stability to address a lot of these health outcomes. But we are also working to change the narrative on poverty. I see this as a reimagination of the social contract. I see this as a way that society is saying to Flint families, we see you, we hear you, we love you. We know it is hard to be a parent, and we are walking alongside you. So I see this as restoring democracy, looking at, we might even see increases in voter participation and civic engagement because of this public-private partnership.
In a place that maybe was the poster child of a city that had been left behind.
Absolutely.
Let me just ask you some of the details that I'm sure people are wondering about. How much will this whole effort cost, and how much money are you raising? How much time are you raising money to do this for?
That's a great question. So to do this for every baby born in Flint, it's about 1,200 babies, so a small city, for the mom infancy period, it costs $7,500 per mom baby. We need $11 million a year to do this. $9 million a year is just the cash transfers. $1 million a year is the research, and $1 million a year is the operation. So it's $11 million a year to do this. We want to do this for 5 mom-baby cohorts, so 5 years of newborns. So we need $55 million. In just a few short months, we have raised over $40 million. The Mott Foundation, based in Flint, started us out with a $15 million challenge grant. Other foundations have come in. And the most exciting news that has happened recently is that we received $16.5 million from the state of Michigan as a TANF redirection. And I think this is worth talking about because this is about policy change. This enables this work to be sustainable and scalable. Luke is a TANF expert, right. So I'm hoping he can kind of jump in and share what that means.
Yeah, let's turn to Luke here. Luke, what is a TANF redirection?
So TANF stands for Temporary Assistance for Needy Families. And it is the federal block grant that replaced our cash welfare program in 1996. And back then, we all thought we were reforming welfare to have a focus on work and to have time limits. But really, the legislation was set up in such a way as to give states the option to spend on cash assistance. And if they did, there'd be lots of requirements and federal reporting. Or to spend on some other core purposes, such as promoting marriage or reducing out-of-marriage births. So these things are actually written into the law. What states figure out over time is that if they spent money in that way, they had to do no sort of justifying it beyond just saying that it could help with one of those purposes. There was no accountability. And so over the years, TANF across almost all states has moved towards states taking the TANF dollars away from cash assistance into other things that they were often already spending on to begin with. So in Michigan, out of $850 million, only about $55 million is being spent on actual cash aid to poor families with children. So that's like 6%.
Wow.
And people, I think, actually across the aisle have come to realize that this is not what was intended with this program. This is not the way we should be thinking about it. And certainly, we shouldn't think of it as like a welfare program, because really, right now, it mainly just subsidizes states for things they were going to do anyways. So this redirection of TANF to bring some of that money back to cash aid, I think has never been done before in this way. And even more importantly, to do it in a fundamentally different way. The old cash welfare program that we had was hugely stigmatizing. Recipients didn't like it. You know, you can think of very long applications and lots of hoops to jump through, or things that you have to do in order to get a small amount of aid. And this is like following exactly as Mona said, a very different message that we are here for you. We're standing alongside you. That's why it's an unconditional program, which we're able to do because we're packaging TANF with philanthropic dollars together.
Got it.
and that we're going to care for every baby in Flint, every single baby.
Now, the amount of money alone is not enough to lift a family out of poverty. But what do you hope that it accomplishes? What are you looking to see as those first checks start going out in January?
Yeah. So, you get into the program, ideally in pregnancy. It's prescribed by your prenatal provider. So some of the first things that we hope to see is earlier access to prenatal care. So we're looking at healthcare utilization markers and an impact on kind of that maternal infant health period. We hope that these payments stabilize, buffer that dip in income, that spike in poverty that happens in the perinatal period. So we hope it stabilizes that. And then other things that we're going to look at, we hope that it brings families, it decreases stress. We hope that it increases trust in government and institutions. We're looking at measures of happiness and hope and life satisfaction for families. So we're also looking at its impact on well-being. We think that it will bring joy. We're hoping that it'll bring joy, and we're also leveraging kind of the arts and music in this effort to really celebrate moms and babies. And once again, Josh, just like all of our work, this is being done hand in hand in humble partnership with our community. This idea was actually driven by our parents and our kids and our families, and they've been part of this whole process. And what we are hearing from families is like, hurry up, start this program. But also like a sense of relief, like, yes, like we've felt ignored for so long. We really thought people didn't care about us. And something like this gives us dignity and enables us to trust again.
That is incredibly powerful. And I will point out that when you jumped in to take on the water quality in Flint, it was a few years later that the entire country wound up getting a massive investment to take lead pipes out of the water supply. And so I imagine as you're thinking about collecting this data that while this may start in Flint, maybe it won't end in Flint.
Josh, yes, absolutely. That is our intent. We're already kind of creating the playbook on how to share this throughout the state and the nation. There's already interest of an RxKids bill in the federal government. But just the work that we did with TANF, just that policy change is something that we hope to share elsewhere. Everything we have done in Flint has not been for Flint. This is not a place-based program. This is something that we hope to share with kids and communities everywhere.
Well, Mona, Hanna-Attisha, Luke Shaefer, thank you so much for joining me in Public Health on Call and in the studio to share this super exciting project. And maybe we'll check in with you to hear how it's going.
I can't wait. Thank you, Josh.
Thank you, Josh.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.